going to proceed from where we ended yesterday. Yesterday we examined the mother. So today we want to examine the baby, and after we examine the baby, we are also going to do nappy change, so that we are able to know how to dress the baby who has just delivered and prepare them so that we don't cause infection and we prevent the infection and ensure that the mother is comfortable. So before we start our procedure of examining the baby, we need to identify the principles, but we start by looking at the indications for this procedure. Okay? So first and foremost, the indication for examining the baby who has just been delivered, we want to assess how the baby is adjusting to the extrauterine life. Another indication, we want to check if there are any danger signs that could be present, so that we provide appropriate health education for the mother, and we ensure that the baby is okay, is able to survive outside the uterus. And the last indication will be to determine whether the baby is able to breastfeed or not. So those are some of the main reasons we need to examine the mother. We examine the baby immediately it is born, and after it is born, we also examine the baby in the postnatal ward before we discharge the baby to go home. Other examinations will be done during observation time, but those are brief ones. But the main examination, immediately it is born, a quick examination is done, and we also do an examination within the first 24 to 48 hours before the baby is discharged. So for us to be able to examine, there are certain equipment that we need to have on hand, so that in case of need, we should be able to use them. We have our mother there with the baby, and then we also need a flat surface where we're going to examine the baby. So this flat surface should be positioned where the mother can easily see. So if the mother, for example, is lying on the bed, and the mother maybe had a seizure, and we want to examine this baby, the mother might not be able to go to the treatment room, but we can still examine on the bedside, either on the bed where the mother is, we create some space where we examine the baby, or we go to a treatment room where we have a flat surface and we'll be able to examine the baby well. So now the other equipment we also need a weighing scale. So this weighing scale normally, remember I was saying weighing of the baby is not an emergency, isn't it? We weigh the baby when we realize that the condition of the mother is okay, she has stabilized, we've cleaned the mother, she's lying comfortably in bed, and also probably before we either transfer to the postnatal ward or after transferred to the postnatal ward, we want to do a thorough examination, we'll need to weigh the baby. So the weight of the baby there, if we check, there's also a tape measure attached there which we can still use to assess the length of the baby. Then we also need the trolley, which will have a tray, and this tray basically we have put a gallipot, and this gallipot contains some swabs, of course, and the cotton wool swab that we are going to use for us to, as we do observations such as temperature checking, for us to clean the thermometer. Then we also have the gallipot here, which is supposed to have if our cord clamp was still in a plastic, we're going to have the plastic place the cord clamp there, but since it's out that the plastic, we've placed it in the gallipot so that it is clean. And then we also have another gallipot. So as we are going to do the rectal temperature checking, we need to put some spirit swabs there, and then we'll be able to check so that we don't mix with these, we maintain these clean in case of need arises. We also need some sutures, because this baby has a cord. Sometimes we might discover that as we examine the baby, we identify that the cord clamp may not be able to have, it may not be big enough. For example, you have the babies who are from diabetic mothers. They will tend to have a bigger cord stump, and the cord clamp may not be adequately able to grasp the cord clamp, so we need an absorbable suture that we can easily wrap around in case there's any bleeding from the blood vessel and control the bleeding. The cord clamp, basically, if the cord clamp that is there is not having a good grip on the cord stump, we need to reinforce and put a new cord clamp. That's why we carried a spare cord clamp. Then we also need a stethoscope, a fetal stethoscope, which we use to determine the breath sounds and also assess the heartbeat for the baby. Then we also have gloves. If we are not necessarily cleaning the cord clamp, we cord stamp, we may use examination gloves because it's not a sterile procedure per se. The sterile gloves will be required if we are going to clean the cord. So we also have put methylated spirit there for cleaning of the thermometer, and then we have put some cool boiled water in case we identify that our baby's cord stamp, there's some dirty particles. We won't just wrap the baby and leave the baby there, but we need to clean the cord so that we ensure that the baby's cord stamp is clean. And that's why we've put there a drum down there containing some swabs, and it also contains the cord scissors in case we need to shorten, because sometimes we find that the baby was delivered and we anticipated that probably this baby could have had could end up with a failure to initiate the breathing, and we left the cord stamp very long. Okay, so we may need to cut the cord stamp and apply a new cord clamp and ensure that it does not become a site for infection. That's why we put our cord scissors down there, not in the delivered part because we don't need to deliver. We have also some linen there. We have some napkin in case during examination, because most babies, they may tend to, if the baby hasn't passed meconium, or they could have passed meconium, but there's still some meconium in the large intestine. As we introduce the rectal thermometer to stimulate the anal sphincter to do what? To open. And when it opens, the baby will pass meconium, and hence we need to change the napkin for the baby. And we have the sheet of forceps that we'll be able to use for removal of the cord scissors or the swabs, and the receiver for disposal of our used equipment. So those are some of the major equipment that we need for us to be able to do the procedure. So now we are going to go ahead with the procedure. So before we start our procedure, we need to also ensure that we talk to the mother, explain what we are doing, and even inform her during the procedure what we'll be doing. So the mother to baby John, we want to do what? We want to examine the baby. Since you delivered, we haven't had a thorough examination. So I want to confirm whether the brief information the midwives gave there is correct. So ask for your antenatal card so that we check for any postnatal guide that they wrote there relating to the baby, whether it was the state of the baby at birth, so that we compare with their findings, and we also relate to what we are going to find now and come up with the appropriate diagnosis. So we are examining the baby on that table there, and we request that you observe whatever we are doing, because so that you'll be able to notice if there's any problem. We'll still be able to inform what we are finding, and then afterwards we'll give you some bit of information based on what we are going to find with the baby. Is it okay we go ahead? Okay, so now before I go ahead, I'll just check and assess if there's anything, whether the mother, there's something that she needs, because remember, we want herself to be there to be observing. So in case she needs something that requires her presence to be assisted, maybe she might say that before you start the procedure, I want to go and empty the bladder, or I want to go and change my pad, then we'll be able to do what we assist her. Say, okay, you can go, I'll remain with the baby, so that she goes. So because we want her to be in the most comfortable position as we are going to examine her. I'll also assess the baby, in case maybe the baby has open bowels, it might affect me examining her properly. So meaning that before I start the actual examination, I might need to do what? To change the napkin so that I'll be able to adequately examine the baby during the procedure. So since my baby is okay, there's no problem, then let me just go and wash my hands, and then after I've washed my hands, I'll be able to get the baby and place her at the right table there for the examination. So since I'm avoiding to be wet, but I wash my hands there, or I do a what? A hand rub. So after I've washed my hands, or I've done a hand rub, then I'm going to ensure that all the nearby windows are closed, because I'm going to expose the baby. Now, if I'm exposing the baby, I don't want my baby to feel cold. I'll close the nearby windows and ensure that if the room has a water thermometer, I'll check what are the readings, and if the room is a bit cold, then there's a heater. I'll switch on the heater so that at least it will be warm enough, because when I expose the baby, when I'm examining, I'll need to expose the baby. So I'll be able to, let me just place the table nearer so that the mother is able to see, and then I can place my treatment this side and be able to assess. So as I said, the mother to John, I've come now. I want to get the baby. Okay, so may I get the baby? So baby John, we want to examine you, and now we are going to place you on the table. Okay, so immediately we come, we are going now to do what? To expose our baby. So after we've exposed our baby, at least the baby is wearing lighter things, then I'll wash my hands again so that I can do the gloving and be able to touch the baby appropriately. So as you do this procedure, ensure that you continuously talk to the mother so that you create that nurse patient relationship, and you ensure that the mother is aware at whatever stage you have reached, for you to be able to examine the baby quite well and ensure that she cooperates and understands what is happening. So follow the normal principles of gloving, where our hands can touch the inner part and the other part will touch with we won't touch them unnecessarily. So basically, we don't want to misuse every possible thing that can be usable. So because of that, and to avoid making my baby lie down on a cold surface, what I'm going to do is I'll get this paper, which is quite light, and place it on the weighing scale. So I'll place it on the weighing scale so that I won't place the baby direct on the scale, because the scale can slightly be cold and I can lead to loss of heat. By what means? Is it convection or conduction? Conduction. Okay. So now as I start examining the baby, one part which I should not expose for a long period of time is going to be the head, because this has the largest surface area, and this is where the baby can easily catch the cord. So briefly, to start with, I can easily, usually during the examination, I'm not supposed to remove the napkin before I reach this side, because there's a danger that if I remove the napkin, the baby passes meconium, can mess up the whole field. Okay? So I can just briefly weigh the baby. So normally when weighing the baby, we ensure that the baby has minimal clothing as much as possible to avoid having excess weight that may occur due to the presence of either it's the nappy that is wet or it's the extra clothing that is there. So the nappy, if it is big, we may remove the nappy and place the baby. But we remove everything and dress the baby, and we weigh. So before we weigh the baby, we ensure that it is at 0, and then we'll start adjusting accordingly until we are able to determine the actual weight for the baby. So after I've weighed the baby, I'll wrap my baby nicely and ensure that the baby is warm. So as I'm going to start examining the baby, first and foremost, I ensure that I only expose the part of the body that I need to examine, so that I reduce on exposure to coldness to the baby. So now for me to examine, I'll use the normal techniques. I'll start by inspecting, then I do the palpation, percuss if there be need, and then I'll also do auscultation. So I'm starting with the examining of the head. So we'll take it for granted, because now we're in the postnatal ward, isn't it? So now, since we are in the postnatal ward, we don't need to start with the APCA scoring, which we had mentioned that in labor, the immediate examination we do, we assess, we do the APCA scoring. So we start by examining the head. Now from the head, I'm going to remove the head sock for the baby so that I expose the baby. Now, what is it that I'm looking for on the head? So I make sure that when I'm examining the head, I place my hand down there to protect the neck of the baby. Because this baby, at this moment, we are saying the head is the biggest part, and if we don't protect the head, can easily drop and we end up injuring the baby. So to avoid the injury, I'll hold the baby gently there and also explain. So now I want to start examining. I'm starting from the head to examining the baby. So on the head, I'm looking at the general shape of the head of the baby. If it is within the first 24 hours, I want to identify whether this baby had to pass through a narrowed birth canal by checking for the presence of the caput succedaneum. So I'll check on the shape of the head. If there was any caput succedaneum, for example, it was a cephalic presentation, you might find that there's going to be, the head might show as if it is lengthened, going backwards. Sometimes if it was this part that was coming, you find that the head could be lengthened coming in front. So I check for the caput succedaneum. So usually the caput succedaneum, if it is present, it will cover the whole head there because it is lying just under the skin, hence even the sutures are going to be covered. But if the other thing I check for apart from the caput succedaneum could be if there's any cephalohematoma. So the cephalohematoma probably is occurring due to some bleeding that occurred during the birth. Maybe for example it was a forceps delivery, as they were pulling the baby, or it was a vacuum. You'd find that if it was a vacuum there could be chignon, but if it was just a pelvic cephalohematoma, you find that the swelling could be one side, it does not cross the suture line. Then afterwards, I'll also check for the, I've checked for the shape, I've checked for the caput succedaneum and the cephalohematoma. I also check for the fontanelles. So on the fontanelles, we said that we have the posterior fontanelle or the lambda, which is like joining the two bones, and then we have the anterior fontanelles. So during birth, when the baby is still a fetus, the most important one is going to the posterior one because we are using it for us to identify the position, isn't it? But now after the baby has been delivered, we are concerned more with this one, which is diamond shaped because of the four bones, because this is where we can easily assess the normal condition of the baby in relation to whether there's some fever or not. So if there's any fever within the head or within the body of the baby, find that there's going to be increased pressure within the head, and here it will be bulging. Okay? There will be a bulge as if it's a swelling. But if the baby, especially even started sucking, you find that it doesn't have a lot of fluids in the body, there's dehydration. Or maybe even at 6 days when they come, if the baby maybe is unwell, had some diarrhea, or probably the mother hasn't started producing adequate milk, the baby will have inadequate fluids and hence here to be depressed or like a small depression going inside there. But normally it's supposed to be straight here normal. So the mother to John, you've seen this part here, it is bulging. It is not bulging, it is okay. But when you observe on this one, it will be like it is beating. The way we check, the heart is beating, this is the way it is here, because there are some blood vessels that are passing. So because of this membrane, it means that you don't need to apply anything. If you apply any help, those helps will start going into the baby and it will affect the health of the baby. So make sure that it is clean, and you should be checking. If it is bulging, it means that the baby could be having some fever, and because of that fever, there is accumulation, excess accumulation of the fevers there. And then also, the other thing that we are checking, we check also on the sutures. Okay? So normally, in a normal newborn baby, you find that these bones, they haven't yet ossified, they are not attached. So there's this space which is being connected by sutures. So this space is not supposed to be widely spaced. If, for example, this baby develops hydrocephalus, excess fluid in the brain, you find that these excess fluids will start accumulating, and now it will start separating these so that these sutures will be widely spaced. So you should be observing the baby at home. If you notice the head is increasing in size and these gaps here are widely spaced, then you know that there could be a problem. You quickly rush the baby to the hospital. Then after I've examined for the sutures and the fontanelles, the bulging, and also the general appearance of the head, the next thing that I want to do on the head is going to assess the head circumference of this head. In a normal baby, the head circumference is supposed to be how much? About 34 to 36 centimeters. So I'll check from here where it is the 1, and then I'm going to put the tape measure surrounding the head so that it will pass just on the sub-occipital through the front of one and down there. Then from there now until these structures, they will be holding each other. I'll reach this side, and then from there I'll be able to assess and determine that my baby's head circumference is at 1 centimeter. So this way, the 1 centimeter is the baseline data that we need now to take note. In 6 days again, we are going to reassess and check whether the head, how big the head has grown. So if the head has grown bigger than normal, it might be indication of hydrocephalus. So we'll also advise the mother to be assessing the baby in the first few months of life. Then after I've finished now, I'm going to come and examine the face of the baby. So on the face of the baby, I start with the eyes to the nose and the mouth. So on the eyes of the baby, I'll start by assessing the color of the eyes. Ideally, the conjunctiva is supposed to be clear. But in the first 24 hours, if I'll notice that there's some yellow discoloration, meaning that this baby could be having some hydrops vitalis, or maybe there's excessive breakdown of the red blood cells of the fetus in the body, maybe like in isoimmunization, where the mother's antibodies will start destroying the baby's fetal blood cells, then you might find that there's excess yellowing of the color. Apart from that, I'll also check if there's some blood stains there, which could be indicating that during birth, maybe the baby bled or something. And then if maybe on the mother's side she had some infection and the fluids from the birth canal ended up touching the eyes of the baby, then we might also check if there are any discharges that are coming out from the eyes of the baby. So we advise the mother to say that right now, I can see that the eyes of the baby, they are clear, there's no any discoloration. But normally as you go home, by the 5th, starting from the 5th, 6th day, you might notice that there could be some yellowing of the eyes. This is quite normal because the baby at birth, they'll have what we call fetal red blood cells. But these fetal red blood cells, they'll start dying because they have a shorter lifespan of only 70 days. So as they are being destroyed, they are being replaced by the adult red blood cells. So that increase in the breakdown of these red blood cells will lead to accumulation of bilirubin, which will lead to the yellow discoloration of the eyes and the other mucous membrane. So that one, it's not a problem. As long as the baby is not crying, it is feeding well, it is normal. What you're just supposed to do is feed a baby more, so that the more milk it takes, the more urine it will pass, and through the passage of urine, it will also excrete the excess bilirubin. So after I've examined the eyes, then I'll also assess the eyes the way they are set. So in the normal eyes of the baby, when you check on the outer canthus of the eye here, the outer canthus of the eye is supposed to be in line with the upper part of the eyelid. But if, for example, the baby has some Down syndrome, you find that probably it won't be in line. Instead, you find that maybe it will be pointing down there. The eyes seem to be low set. Sometimes, even when you look at the eyes, they are low set. You find that in the normals, it's supposed to be appearing on the middle part, but you are able to see the upper part of the eye and the eyes are at the bottom part, like the way the sun looks like when it is setting. Then you know that here we could be dealing with a baby with the Down syndrome or hydrocephalus. Then after I've assessed the eyes, the discharge, and the set that they are lying in line with the symmetrical to the upper part of the ear, then I'll also check on the nose. On the nose, we now need to check to assess to determine whether they are blocked or not, because we want to check and ensure that they are not blocked, the airway is able to pass adequately. So to assist me, I might also I just leave the baby comfortably there. I could also get, whether it's a small paper like this one, I put it just gently in front of the nose there. So if the baby is breathing properly, find that it will be moving according to the air that is coming out of the nose to help me know that the nails are not blocked and they are clear. Then afterwards, I'm going to examine now the mouth of the baby. So in the mouth of this newborn baby, the major things that I'm examining, I'll start by opening the mouth and assess in the mouth what is the color inside the mouth. If the upper part of the palate there shows some bluish discoloration, it means that there's some cyanosis, which could be indicating alteration in the respirations or gaseous exchange. But I need to also assess whether there's any palate or not, cleft palate. So normally I could, if I was using the examination gloves, I could wash my hands and get sterile gloves, and then these gloves now, I'm going to insert my middle finger there and pass through on the upper palate to assess whether there's some gap that I feel an opening there. Because if the cleft palate is there, then we find that the baby will have challenges with breastfeeding. It's trying to breastfeed the milk instead of going into the GI tract, it will go first upper there where there's that opening, and then as it comes down, it might go into the respiratory tract and leading to choking. So after I've examined for the cleft palate, I'll also check on the tongue, what is the color of the tongue. So if the baby has already started breastfeeding, I might notice that there could be some curds, there are milk curds on the mouth. So immediately as I try to push a bit, they can easily move out. But if there's some infection, you might notice that the baby has oral candidiasis, and then when you try to move them, they won't easily move out because these are some cells that are growing, the candida that is growing on the tongue. Then after I've checked for oral candidiasis, the next part that I need now to check with is going to be the gums there. On the gums, I want to assess, do we have any false teeth? If there are any false teeth, sometimes the baby can just be referred to the clinic so that the surgeon is able to pull them. And if there's nothing, then we are going to also just confirm whether the lips are dry. Then after I've assessed on the mouth, then I'll also assess on the ears. Okay? So on the ears, I want to assess, also confirm the maturity of the baby. If the baby is mature, you find that there's going to be soft tissue there, there's the soft tissue that is present, and then the ear is able to be well fixed there and placed. But if it's a premature baby, you find that this is tend to be flabby and it will be like stuck to the head of the baby. Then I also check for any discharge to rule out any ear infection, or sometimes if, for example, there's some discharge, I need to get some cotton wool, okay? So that when I get this cotton wool, I'll try to swab a bit to get this discharge and check. If the discharge looks to be a bit yellowish, isn't it? It could be maybe during delivery there was some rupture in the head, and then there's now some spinal fluid that is flowing through the ear. Sometimes they can even be blood. If there was any injury, there was a birth injury, that can be noticed. So I'll just swab if there's some discharge, so that I check and assess whether it's spinal fluid, cerebral spinal fluid, or maybe it could be some injury that could have occurred during delivery. So after I've finished examining the ear, the next thing now, I'll cover the head of the baby. I avoid any exposure. Then after I've covered the head of the baby, then I'm now going to examine the neck of the baby. So on the neck, I will inspect to assess for any webbing. So if there's any webbing, we find that there could be excess strands of tissue there that is trying to attach there. Yeah, remember the other day we had talked of something like the way the duct is there will be that membrane that is attaching. Then apart from that, the other thing that we check also, we check if there's any goiter. Remember, when the fetus is in utero, whatever is flowing in the maternal blood may end up going into the fetal blood. So if there was excess iodine that was passed on, this baby could have some goiter. So you have to assess and check for any goiter. And then after I've checked normally the neck of the baby is going to be short. So after we've examined the head and the neck, the next part now, we want to examine the chest of the baby. So on examination of the chest of the baby, we expose the baby. But before we examine the chest, we start by examining the limbs. Okay? So we start by examining the limbs of the baby. So when examining the limbs of the baby, basically here we want to check and confirm the number of the fingers. So we count the number of the fingers in the hearing of the mother. Because if you are going to have any abnormality and then you tell the mother to say the baby had 6 fingers, when she reaches home, because her tradition, extra digits is what? It's a taboo. She'll say, no, me, the nurses, they changed my baby had 5 fingers, but they've given me the morning star with 6 fingers. So you need to explain, count with the mother. I want to count how many fingers we have. 1, 2, 3, 4, 5. Now, if we have an extra digit, we can palpate and feel whether there is any bony growth. If there's no bony growth, then we'll be able to explain to the mother, we can't feel any bony growth, it seems to be just some tissue. So refer to the doctor, or if, for example, I'm at the clinic, I'm alone, I've examined, assessed, there's no bone there, then I can just get this, isn't it? So I get this, and then from here now I'm going to get the suture, not the needle, but the suture, and this suture now I'm going to tie around that extra digit, so that after some days, when there's lack of blood supply, it will just necrotize and fall off and remain with the normal number of fingers. So after we examine the hearts, then the next part we're examining is going to be the chest. So on the chest there, we start by checking on the chest circumference. So normally we anticipate that the chest circumference could be about 33 to 35 centimeters. So we ensure that the tape measure is passing on top of the nipples there, and then it goes across behind, and then from there we are able to assess and count. And after we assess, then we check how many centimeters. In a normal fetus, in a normal baby, it should be about 33 to 35 centimeters. Then after we've assessed the chest for the fetus, we are now going to check on the respirations. Is the chest moving up and above? So remember we had mentioned to say that babies are normally diaphragmatic breathers. So the diaphragmatic breathers, it means that we are also checking the diaphragm whether it is rising normally or it is abnormal. So after we check the rising of the chest and the flow and the rise and drop of the diaphragm, we've checked the chest circumference. Then we are going to also count the respirations. So in a baby, you can't check the pulse, but normally we check the article pulse for the heart rate. So we get that, and then normally if we're not the ones using it, we have some spirit there, we just clean our stethoscope, and then after we clean our stethoscope, then we are going to assess and listen to the movement of the chest. We count for a full minute what are the beats we are feeling, and then after we've counted, then we are going to record and take note of the beats. So for the heartbeat, normally we anticipate that you have 100 beats and 100 to 120 beats per minute. Those are the normal beats for the heartbeat. Then the respirations, normally we anticipate the 3 to 6 breaths per minute. So after that, we have confirmed. And then the other thing that we might check for, if it is then after we check the respirations, then we come and assess on the abdomen. So on the abdomen, we start by inspecting the abdomen. Is it full? Then is the membrane present? Okay? If the membrane is not present here, then we can end up having an abnormality. So we can end up having, for example, what we call exophallus, because we are seeing that there's no membrane, we are able to see the intestines inside. Then apart from that, we are also now going to assess on the cord. We want to check on the cord. Remember at birth, we had counted the number of blood vessels. So if within the first few hours of delivery, now we are doing a thorough examination, isn't it? So with this thorough examination, we just wipe on top to ensure that it is clean and count how many blood vessels are there. We anticipate that we have 2 arteries and 1 vein. Then we're also going to check how much of the Wharton's jelly is present. Normally, in a normal baby, the Wharton jelly should not be so much, and that's why the cord clamp can easily attach. But sometimes in a diabetic baby, you might find that the Wharton jelly could be a lot due to excessive glucose that was passed on to the fetus. Then after we've checked the Wharton's jelly, we've counted the number of blood vessels. We also want to check, is the cord clamp well attached? Or are there any strands showing that there was some bleeding that could have occurred? If it is well attached, then it's okay. If there are any signs of bleeding, then we'll change the cord clamp and put a new clamp that will easily control the bleeding. And then also assess the color of the cord clamp. Usually in the first 24 hours, we are going to have the cord clamp that is still fresh, the way it came out from the fetus, from the stomach or the uterus, and then it will have the Wharton's jelly. But if we are assessing this baby at 6 days, we anticipate that due to the cord clamp that and the prevention of blood supply from the mother, you find that the cord clamp will have started shivering and due to necrosis, so that it is going to dry up and drop off with the necrosis. Then we'll check also on the stump there if there are any signs of infection. If there's infection, there could be some heat, or there could be some signs of some blood discharge surrounding the cord stump. So after I've checked for that, then now we are going to proceed. The cord clamp is okay. We'll just gently palpate to feel if there's any pain for the baby. If there's any discomfort, we'll notice the baby will cry to show some signs of not being happy, and then we know that there could be a problem. This might happen especially in the baby when the milk has started being produced. If the baby is being overfed, you find that the stomach could end up becoming very full. But sometimes the problem is if the anus is not parted, you find that the abdomen will look very full, and because it is stretched, it will even look shiny because of the meconium that hasn't been passed. So after we've assessed, palpated, everything is normal, then the cord stump is clean, it's normal, or maybe it is dropping off, then we are going to proceed to examine also now the lower limbs. Okay? So on the lower limbs, we want to assess and ensure that there is symmetry. Okay? There's good symmetry. And then apart from the symmetry, we also start by examining the number of the digits there. After we've checked the number of the digits, we count them. If there's any extra digit, we are going to tie the way we had tied with the limbs. And then we also check on the palm there. So we didn't measure even on the hand, but even here on the palm, we want to assess whether the creases have developed. If there are no creases, it's just smooth, then it means that this baby is still not, it was born as a premature baby. But if it is a mature baby, you find that there are going to be some creases on the palm, on the pedal there of the fetus of the baby there where it steps. Then after I've checked there, I'll also check on the other side, count the number of digits. assess if there are any creases observed to indicate maturity of the baby or not. Okay? Then after we have finished on the legs, now we are going to examine the perineum to assess the maturity, the perineum of the baby, isn't it? So we remove the gloves that we are wearing, we wash our hands, and we are going to expose the baby. So we expose the baby by removing the napkin. So we have to assess and check what is the sex of the baby. So initially we started by checking on the postnatal readings for the mother, and there during delivery they would have identified the sex of the baby, isn't it? So we also need to check and confirm the sex of the baby, whether it is a female or it is a male. Sometimes there could be ambiguity of the sex, whereby you are seeing some growth there, but you cannot really differentiate whether this baby it is male or not. If it is a female baby, normally you may get a swab, okay? After you get the swab, in the first 24 hours, due to the withdrawal of the hormones that the baby was receiving from the mother, you may find that as you swab there could be some mucoid blood-stained discharge, which we call that it's a pseudo-menstruation. It is normally associated with the female babies. And then if it is a male baby, we need to check also and palpate gently. So we first try to pull the prepuce backward so that we want to assess on the urethra. Is it centrally located? If we are lucky, the baby might pass urine. So as the baby is passing urine, we also check how is the flow of the urine. Is it coming centrally or it is coming underneath the central part on the bottom part? If it is coming through from the bottom part, it means that the baby could be having what we call hypospadiasis. If the baby, the urethra is on top of the normal central opening there, then this baby could be having what? Hyperspadiasis. Or it could be centrally located, it is normal there. Then from there now we are going to gently palpate the scrotum to feel whether the tests have descended. Okay? Then if they haven't descended, we palpate and feel in the inguinal region so that we advise the mother to say we are not able to feel the tests in the scrotal sac, so the baby should be brought again for further review. And normally, by the time the baby is 3 months, we'll be able to determine whether the tests have finally descended. If they haven't finally descended, it means that after 6 months or maybe even after 18 months, the doctor might decide so that they take the baby for operation where they are going to be able to manually descend the test. Because the fear is that if the tests remain undescended, then due to the heat of the body, then it might lead to the destruction of the sperms and the baby might end up becoming infertile. So for the male baby, that's what you check for. For the female baby, you assess if there's any pseudo-menstruation that could be present. Then after you've examined, you have identified the genitalia, then you are going to gently turn the baby on the lateral side. So as you turn the baby on the lateral side, you start by inspecting the spinal cord, the back of the baby. Are you able to notice anything? So there are times when, due to some deficiencies, for example, folic acid deficiency, it can affect the growth of the central nervous system, leading to conditions like spinal bifida. So if there's a spinal bifida, you might notice that maybe somewhere here there's a membrane. The skin is not continuous. There's a membrane where you're able to see the inner structures there. So that is a spinal bifida. But there are times when, because you know that the spinal cord, it is also made of 3 layers, isn't it? Okay, the meninges. Now you find that sometimes the skin also is not there, and then that might affect the development of the meninges. So you find that some babies, they can have some bit of hairy stuff there. So when there's some hairy stuff there, it could be indicating the presence of a meningocele. So you check for a meningocele, you check for a spinal bifida. These normally may occur due to deficiencies for nutrients such as folic acid. And then afterwards, you are going to gently, for example, when you gently apply pressure like that on the cord of the baby, okay? When you gently apply pressure like that on the cord of the baby, due to that sensitization, the baby will try to do what? To wiggle its back. You're able to see the baby wiggling. Then you know that the central nervous system is well developed. Then after you have finished now examine the back, you also now examine the anus. Okay? So you examine the anus, you want to identify whether the anus, the anal opening is parted or not. If you have a rectal thermometer, this is where now you get your thermometer and you are going to dip methylated spirit, wipe it nicely, and then afterwards you get your rectal thermometer, you try to insert in the anal opening. So if you are failing to insert the rectal thermometer, then usually it could be this imperforated anus. If you are able to perforate, then you leave it, you insert and leave it for about a minute or so, and then you'll be able to check the temperature. So you have to be very cautious. After what you've inserted there, you have your swab, because in most cases, if the baby had not passed meconium, as it comes out now, you find that there will be some meconium staining, and then you have to clean the thermometer nicely and pack it there. Then afterwards, you are going to wash it with soap and water. Okay? So after you've confirmed the anus, the anal opening is well, it's perforated, the next thing that now you are going to do is you cover the baby up there, and then now we want to examine the central nervous system. So on the central nervous system, basically examination of the central nervous system, we are assessing the presence of the reflexes. So there's some of the reflexes that we assess for. So remember, we have covered the baby nicely. We can get, for example, if I got this, okay, I fold it nicely. After I fold it nicely, isn't it? Then I have this nice thing there, and then I'll gently try to put it here and move it here. So when there's what we call, when you're assessing for the rooting reflex, as I put it there, this baby now will start turning the head towards where it is feeling the cessation. That's what we call the rooting reflex. And then after I've checked for the rooting reflex, I might also check for the sucking reflex. I can either remove my glove, okay? I remove my glove, wash my hand, and then gently place, for example, the middle finger inside the mouth of the baby. If I gently push the mouth in the mouth of the baby will try to suck the finger. But due to the presence of HIV, sometimes it's not very much advisable because of the danger of you might end up getting in touch with the secretions and the like. So the other alternative, you can still, after you've finished, you give the mother and you assess, as you advise the mother to say, I want to observe the baby breastfeeding. So if the baby is able to grip the areola nicely and suck, then you know that the sucking or swallowing reflex is present. So it's able to suck, and then you wait to observe whether that milk which was sucked, it is kept in the mouth. If the baby is not able to swallow, you find that after it has sucked the milk, it comes from the mother, the milk will start dripping. It is also one of the signs we may notice if there's going to be a cleft palate. Okay? The cleft lip, normally you can see the division here, the mouth, it won't be completely. So after you've checked for the rooting reflex, you've checked for the swallowing reflex, then the other reflex that we normally check for is what we call the moral reflex or the stator reflex. So if I'm doing the stator reflex, I'm holding the baby like that, isn't it? I raise the baby gently. Then after I raise the baby gently, I've put this hand to provide the support, and then I do this. So as I let go of this baby, you find that to raise the hands as a reaction, as if it is trying to grasp somewhere. Even the legs there, you might see the legs doing that. It is because of that fear that it is falling down, and then now it will react like that. That is what we call the startle reflex. Then the other reflex that is important, which we should be able to check for, is what we call a primitive walk. So the primitive walk is, for example, I get the baby like that, isn't it? Then after I get the baby now, I will try to put it on the table there. So as I put the baby down there, usually the baby will react by making a giant step. So that giant step, we call it as the primitive walk. Which other reflex have we looked at? Grasping reflex, isn't it? Yes. So now, after, when I want to assess for the grasping reflex, I'll get either my middle finger or my finger, any of the fingers, I try to put it in between here. So normally when I put it in between here, the baby will try to grasp the finger. Then I know that it is the grasping reflex, it's present. Okay? Then the other reflexes that we may, so these are the main reflexes that we can check as we assess the baby. We assess for the swallowing reflex, after we assess for the rooting reflex or the rooting reflex. Then we also assess for the moral reflex or the startle reflex. We also check for the swallowing reflex, the sucking reflex, and we check for the grasping reflex. So all these reflexes, we anticipate that in a normal baby at birth, they should be present. Then the other reflexes normally will be developed later on as the baby grows. For example, we have the blinking reflex. You might not expect the baby to blink there, and then no. But what we may assess for is we can still assess for the senses. Senses such as if the baby's eyes are open, I move this object like that. As I move this, the baby might start following that, and then you know that this reflex is, this says it's present. And if we also want to assess, for example, the hearing reflex, sometimes like the baby is dying like that, the way it was there, allow someone to just bang the door there, or I do that. And when I do that, the baby might do what? It will cry because it has heard the sound which was not comfortable for it. So I'll be able to check for those senses. The other reflexes, we may not necessarily check them, but we know that their presence. For example, the taste reflex. The baby normally will prefer the sweet things as it breastfeeds the mother's milk. But if the baby, for example, is not well, we give them Panadol, which is very bitter. It might also indicate that it will start doing as if it wants to spit. Then you know that the taste reflex is present. So basically, those are the main issues that we follow through. Now, after we've examined the baby, we have finished all the examination, isn't it? The next other examination that we haven't done, which we should do, is going to be the length of the baby. What is the length of the baby? So normally with the length of the baby, we make the baby lie down on the lateral side, isn't it? So we start from the top there, where we're going to put our tape measure there. Now the baby, we don't measure the way we measure the adults, isn't it? Because the adult, we have that measure for the adult, we make them stand and they'll face that time. But for the baby, because they cannot stand, we are going to place our measure here at the highest point there. So after I've put the tape measure at the highest point there, then we are going to make sure that we push the tape measure like that. We pass the tape measure. We allow the tape measure to flow like that. When it reaches there, we follow, for example, one of the limbs. And then, because remember I had said we check the symmetry of the limbs, isn't it? Mm-hmm. So it means that they are of the same length, and then we go to the lowest point there on the end of the foot, and then we are able to check the length, and we anticipate that in a normal one it should be about Is it 53 to 55 centimeters length for the fetus of the baby? But depending on where this baby is coming from, isn't it? Right? Yes, some people might go now and check on someone here. I won't mention names. Isn't it? So they are short, so even the baby might tend to be short. Let's not be staring at people. Isn't it? Okay, so now we have finished. We've measured the length of the baby. The next thing that now we mentioned we are going to do, remember we had addressed the baby. So now we are going to demonstrate how to apply, put the nappy, which can be done even when we are changing the nappy of the baby. So remember, we ensure that at all times, the parts that are not examined are covered. So the head of the baby, it's covered. We tie nicely there and ensure that it is well protected. So on the nappy there, as we are going to apply the nappy for the baby, we have this nappy that is there, which we might fold according to the size of the baby, but we make sure that it has the 4 squares, isn't it? Then we get this corner here and go to the opposite corner there and put the nappy there. Then after we've done that, we are going to create a fold there. Okay? So after we've folded our nappy there, then we place our nappy down nicely on the flat surface, and then we are going to get our baby and place on that surface, isn't it? So when we place our baby like that, we make sure that the nappy, at least the bums of the baby are covered within the nappy, isn't it? So we take the first envelope-like appearance there, then we are going to wrap the perineum of the baby there so that we protect the baby. Then after we've done that, we can get this end corner of the nappy, pass it on top, then under the thigh for this other opposite leg, and either pass it down there. Okay? So that after we've passed it down there, then we get this corner now, bring it on top, and then as we bring it on top, we ensure that we don't wrap the knees. They are free to move, and then we bring it at the bottom, and then we are going to tuck it underneath the fold we had created. So after we've tucked there, we are able to see now the nappy is not dropping, and in front here our cord stump is exposed, so that when the baby passes urine, it will just wet the nappy there. This part will remain exposed, so that it will help for the reduced introduction of other substances on the cord, and also ensure that it remains dry at all times, and it will help for the cord to dry faster. Is that okay? Yes. Then we also know that there are certain traditions when you are dealing with a male child, isn't it? There are other traditions with the male child. As you'll be cleaning the cord, there's a tradition where they say if the umbilical cord drops on the male child here, then there's a tradition that that male child will become infected or impotent. So I don't know how true it is, but there are some of those traditions. So after we have dressed the baby nicely, then we are going to wrap the baby so that we give the mother the baby, and the baby is going to be warm. So ensure that we are creating an envelope-like appearance so that we cover there. We are going to cover, we start by covering the feet there, and then this part, we are going to raise it nicely. We tuck the baby like that, and after we've tucked the baby, we apply there, we tuck behind there, and then we get this part also, we apply like that, and then we are also going to get the shower or the blanket for the baby, whatever linen is present, and then we are going to wrap the baby in a similar manner like the way we had done with the initial part. So we place the baby nicely there. We have our linen there so that we wrap the baby, ensure that this covering is coming up there and protecting the head nicely to avoid any drought to be able to enter there. So at the bottom there, we ensure that also the legs are well covered nicely. Then we wrap our baby there. We keep only the face exposed, and then we get the other part. Okay, the other part which is supposed to also be folded nicely, and then we wrap our baby. So after we've wrapped our baby now, you've seen there the baby is looking? Yes. The baby is looking nice. Then we're able to give the mother. So after giving the mother now, we are going to explain to the mother, so we were examining the baby and we found that everything is normal for the baby. So we advise you, the way you saw how we are putting the nappy, isn't it? We also want you to ensure that at home you avoid the nappy covering the cold stamp until it drops, so that it will be promoting proper drying of the cold stamp. Ensure that at all times it is dry. And then when it is exposed like that, it will also be easier for you to note if there will be any bleeding that can occur. You also observe the cold stamp for any yellowish discoloration which could indicate some jaundice. If it is severe and the baby is crying, then you know that it is not normal for a baby to cry anyhow. The crying of the baby is supposed to be just to tell us, and even the cries sometimes can differ. For example, if it is a sharp, high-pitched pain, it could mean that the baby is having some fever. But normally, if the baby, it is normal, it just want to feed, it will just have a short cry, then you're able to feed. Or sometimes maybe the baby has wetted itself or it has opened bowels to have that small cry, and then you're able to change the nappy for the baby. So ensure that at all times you keep the baby dry as much as possible, because if you keep the nappy which is wet for a longer period of time, it might lead to development of rash and also lead to some discomfort to the baby. There could be excoriation because of the ammonia there, the nitrogen which is present in the urine can start irritating the skin. And then also we observe the skin currently, it's okay, the color is good, there's no any abnormal discoloration. So as you are going to start bathing the baby, you also need to do what? To observe the type of soaps you are using. In most times we advise the soaps that are plain color like white, because they have less chemicals and they might not lead to irritation of the skin. Or sometimes the other type of soap, it's soaps like yellow or the red soap, where those days used to have apple. That one contains minimal chemicals and it will lead to less reaction to the baby. Then apart from that also, you need to also ensure that you observe the baby, the times when the baby is sleeping, so that you also have time to rest. Then I would like to also see you breastfeeding. So the baby should be, in the first 6 months, you should breastfeed the baby exclusively without giving any water, so that you avoid introducing some water which could predispose to poor digestion of the milk and also might lead to some discomfort to the baby. So the milk that the baby is breastfeeding from your breast, usually it will contain adequate fluids and adequate nutrients that are appropriate for the baby. So you need to ensure that you are also relaxed when you are breastfeeding. You lie in a comfortable position, or if you feel comfortable while seated, then you can still breastfeed while seated. Then you also educate the mother on some danger signs that the mother might notice. For example, fever. Sometimes they might notice also even the fontanelles, if they are bulging, they are not pulsating, it could be indicative of the fever. Then you also advise the mother to observe for the type of stool that the baby will pass. If the baby is exclusively breastfeeding, normally we anticipate that the baby might not be opening bowels every day, because the milk is almost digested, so it will easily be absorbed. Then afterwards, you also inform the baby to say, if it is before discharge, you inform her to say that now that the baby has been discharged, here we don't normally give the BCG vaccine. it should be given within 13 days. So we advise you to go to your nearest clinic within the next 13 days so that the baby should be given. Preferably at 6 days, you take the baby to the nearest clinic. They'll give them the BCG injection, which will be given on the left arm there. Then after they inject that, they'll be able to advise, because after 6 weeks, your baby will start immunizations. For example, DPT and the oral polio. The oral vaccine, normally, it should be given from the labor after the baby is discharged. We might give them OPV 0. But if the OPV 0 is not given, we also advise them to say at 6 days, you go to the clinic so that they'll give the OPV 0 and the BCG vaccine. Then you also give appropriate IEC, whether it's about how to take care of herself, she needs to rest, she needs to eat, and also you educate her on the importance of breast care. So basically, after you finished giving the advice to the mother, the next thing that we do now is going to be to dismantle the trolley. You dismantle everything that you're using for this procedure. You remove, afterwards you wash your hands and remove the gloves. Then you are able now to come to the mother and explain, so no, thank you very much for your cooperation and assistance. So now we are going to discard. May you lie comfortably, remain with the baby. You dismantle, then you go and report to the ward manager. I've done what? I've examined the baby on baby John. I didn't identify any abnormalities. The observations are within the normal range, and also the mother is okay, and mother shows the signs of understanding the advice given. Then I'm going to record in the book where we normally record, and then we